Headache is a common complaint, even more frequent than the common cold. It is an almost universal experience and one of the most common symptoms in medical practice. Headaches account for approximately 3 million visits to the emergency department per year in the United States. In an outpatient setting, most headaches will be benign. A headache is defined as the irritation, stimulation, or agitation of the dura mater, cranial nerves, particularly the trigeminal nerve, and neck muscles, which produces pain in the head. Pain receptors are located in arteries and veins at the base of the brain, throughout the meninges, and in extracranial vessels, scalp, neck, and facial muscles, paranasal sinuses, eyes, and teeth. Head pain is mediated by the 5th and 11th cranial nerves and upper cervical sensory roots. Headache etiology can include local intracranial causes like inflammation, vascular issues, and changes in intracranial pressure. Local extracranial causes involve soft tissue or referred pain from the eye. Other causes include middle ear infections, sinus problems, dental pain, neuroglia, metabolic factors like hypoglycemia, toxic factors such as fever, and psychological causes like tension, anxiety, and depression. Headaches are classified into primary and secondary types. Primary headaches, such as migraines and tension-type headaches, are standalone conditions. Secondary headaches are symptoms of an underlying medical issue, like trauma or infection. This slide shows a continuation of the secondary headache classifications. Primary headaches, including migraine, cluster, and tension-type headaches, represent over 90% of all headaches. Secondary headaches are symptoms of an identifiable, distinct pathologic process. When taking a headache history, ask about location, severity, and character. Also inquire about associated symptoms like nausea, light and sound sensitivity, and autonomic symptoms. Migraine is the most common cause of episodic headache. It is characterized by severe headache attacks, sometimes preceded by an aura involving neurological symptoms. Episodes are often associated with sensory sensitivity and nausea. The lifetime prevalence of migraine is at least 18%. Many women report an association between migraine and menstruation. After menopause, women tend to experience fewer migraine headaches. Migraines are primarily neurogenic, starting with spreading cortical depression, which is a wave of neuronal depolarization. This process is thought to cause the migraine aura. The headache itself results from the activation of the trigeminal nerve. The trigeminovascular system is central to the pain mechanism. Activated nerves release chemicals like CGRP, which cause vasodilation and inflammation of the meninges, leading to pain. Sensitization of trigeminal neurons and brainstem pain pathways makes typically harmless stimuli feel painful. Migraines are influenced by genetic, environmental, and neurological factors. Migraine without aura, or common migraine, is the most frequent form. Classic migraine, or migraine with aura, includes specific reversible neurological symptoms preceding the headache, such as flashes of light or tingling. Migraine headaches are chronic and recurrent. They are often unilateral, pulsating, moderate to severe, and exacerbated by activity. They can last from 4 to 72 hours and may involve nausea, vomiting, and sensitivity to light and sound. Classic or aura migraine is preceded or accompanied by a neurological disturbance. The aura includes visual disturbances like zigzag lines, sensory changes like tingling, and sometimes speech difficulties. Ophthalmoplegic migraine is a rare syndrome associated with ocular nerve paresis, most commonly the 3rd cranial nerve. Secondary causes like an intracranial aneurysm must be ruled out due to the neurological abnormalities. Hemiplegic migraine is a rare, severe type characterized by temporary paralysis on one side of the body during the attack. The neurological symptoms typically last 30 to 60 minutes, followed by a severe pulsating headache. Basilar-type migraines involve an aura related to the brainstem and are associated with multiple neurological findings, including visual symptoms, dysarthria, vertigo, and altered consciousness. Routine neuroimaging is usually not required for typical recurrent migraine headaches. However, it must be considered for new-onset headaches, seizures, or to rule out secondary causes like tumors or structural lesions. If indicated, investigations may include CT or MRI scans of the brain, laboratory tests like ESR or CRP, and an EEG if seizures are suspected. Treatment options include analgesics such as acetaminophen or NSAIDs. For nausea or vomiting, metoclopramide can be used. DHE and triptan-class drugs, which cause cranial vasoconstriction, are also used to treat migraine attacks. Cluster headaches produce severe unilateral, sharp, stab-like pain, often around the eye. They recur in clusters and can awaken the patient from sleep, with each attack lasting 1 to 3 hours on average. The pathogenesis of cluster headaches involves complex interactions among the trigeminal pathway, the trigeminal autonomic reflex, the hypothalamus, and neuropeptides like CGRP. Treatment for cluster headaches includes high-flow oxygen, sumatriptan, DHE, and a short course of oral prednisone. Tension headache is the most common recurrent pain syndrome, affecting over 78% of the population. Stress and lack of sleep are frequently implicated as triggering factors. Patients describe a tight, band-like discomfort around the head that is non-pulsating and dull. This discomfort does not typically worsen with physical activity, and symptoms like nausea or light sensitivity are unusual. Treatment for tension headaches includes analgesics such as acetaminophen or an NSAID. Non-pharmacologic regimens include meditation, massage, biofeedback, and psychotherapy. This video's content is based on the following references: Kumar and Clark's Clinical Medicine, Muhammad Enam Danish Medical Diagnosis and Management, and Davidson's Principles and Practice of Medicine. This slide asks if there are any questions, but since this is a video, you can direct questions to the video's creator or source if available. Thank you for watching this video on headache management and diagnosis.